Good afternoon and welcome to Evergreen Family Medicine's Facebook and YouTube channels. I'm Brian Prowitz, your co-host for a few minutes anyway, for another episode of Evergreen Talks. And today we will be hearing from Dr. Tim Powell, the CEO of Evergreen Family Medicine. We'll be talking about chronic pain. But a couple of things before we turn it over to Dr. Tim. First of all, every second Thursday of the month, we're here with Evergreen Talks at 4 o'clock. We encourage interaction and live questions. So if at some point during Dr. Powell's presentation you have a question, feel free to enter it into the comments and we'll be able to see those. And at the end, we will take some questions and we would love for you to chime in so that we have some other things to potentially talk about and certainly answer your questions so that you come away from this with more information, which is very much the point of this presentation today. Evergreen Talks is a monthly Facebook Live event where the physicians and providers and specialists at Evergreen present topics that matter to you. So once again, Dr. Powell, it's good to see you, and we're looking forward to your presentation.
Brian, thank you. It's good to see you here. I really appreciate all the folks that are signed on to this. The town hall that Evergreen does is really important to us. It's a way to connect with the community, share things that are important to us, and I hope are important to the community as well. So today's topic has to do with chronic pain and chronic pain management. I have to acknowledge that may seem kind of a downer subject to speak of. We'll work on it. We'll try to get better. Next month, we'll try to do something more upbeat, maybe something having to do with thrombosed hemorrhoids or something that's more fun. But chronic pain, in truth, is one of the more common issues we deal with in primary care. In family medicine, everything's fair game. It can be nail fungus to delivering babies, to heart disease, to hair loss. And so everything's fair game. And one of the more common issues that we deal with in primary care is chronic pain. And it's one of the most difficult. And so I thought it'd be worthwhile to share with folks on a community level, because if it's difficult for us, I'm quite certain it's difficult for others in the community as well. I need to start with this. Patients with chronic pain suffer greatly. That fact is beyond any argument, and so does their family, and so do many providers in their attempts to help them. None of us chose this. In the next slide, we ask the question, we go from how did we get here to how can we help? And I will say this, most traditional medical treatments for chronic pain looks at reducing or managing pain sensations. And so we use painkillers, we use opiates, muscle relaxants, antidepressant drugs are a common thing for us to use. Sometimes we use surgery, sometimes we use injections. And so the next slide asks the question, how's that working for us? Because a lot of folks think, we really should do more. Let me tell you a story. The citizens of Sweden enjoy one of the highest standards of living and the best working conditions in the world. Everybody in Sweden has access to free and high quality healthcare. They have excellent education, including university study, which is entirely free, open to everybody. Nowhere in the world is there more vacation time, a shorter work week, a greater number of holidays, longer maternity leave. At the same time, Sweden has more workers on sick leave and work-related disability due to chronic pain and stress than anywhere else in the world. Sweden also has one of the highest rates of suicide in the world. The next slide asks the question why that might be. And instead of doing more, maybe we should do less. The Swedish government did a comprehensive study of all established medical treatments for pain. This was their conclusion. The best treatment a primary care physician could give a patient with chronic pain was nothing at all. providing no treatment at all, had far better outcomes than any of the medical solutions they offered. Now that has to be just crazy. How could that possibly be true? Let's look at the next slide. And part of that may reflect the paradox of how we view pain. Pain has always been an inevitable part of living. Humans have dealt with pain in much harsher living circumstances in the past. When pain was unavoidable, we tolerated it. But when pain became avoidable, it seemed to become intolerable. The next slide shows the US more experience. And I will tell you, going to the next slide, as far as the US plan, there was a time when American doctors were vigorously pushed to treat pain. We were pushed by our medical societies, our professional societies, even our state boards. Pain was called the fifth vital sign. In Oregon, a Douglas County doctor had the distinction of being disciplined by the Oregon Medical Board for undertreating pain. Because between 1993 and 1998, this doctor was found guilty of not prescribing enough drugs to alleviate pain in 6 patients. And so he was required to complete education on pain management and undergo, he was ordered actually to undergo psychiatric treatment. Now, people responded differently to that decision by the board. The director of pain management at Oregon Health Sciences University lauded the decision. Meanwhile, the president of the Oregon Medical Association, who's actually a practicing physician, questioned it. His quote was this: "Current fashions should not shape medical care. It's going to be difficult for the average Oregon physician to know what to do." On the other side, advocates of better pain treatment said doctors just need to educate themselves about current medical thinking and get over it. Ironically, these are the very people who are now punishing providers for overprescribing. Next slide. So America eventually came to the same conclusion as Sweden. What we created with all of our administration of painkillers, pain medicine, pain management strategy is an intolerance to pain and an increased sensitivity to pain. But it's a very seductive process. Patients hurt. They truly hurt. And doctors want to help. And in the short term, narcotics help. In the long term, the patient arrives at a point where they need the drugs to feel normal. It controls their life, but their pain level is not different from what it would be if they never started the opiates. Now, I will guarantee you there's a lot of folks listening to this presentation who will vigorously disagree with what I'm saying right now. But we have done surveys. It's a part of our process. Before we begin somebody on narcotics, we do self-surveys. The patient fills this out, their pain level, but also their level of function, their life quality. And then after 6 months, 1 year, 2 years, 3 years of treating that with our management, including narcotics, we do the same surveys. And what we find is that the scores are not improved. The patient rates himself as in the same circumstance, but now they're on narcotics, which they need to maintain that same circumstance. Next slide. In the meantime, what we've brought about are some unintended consequences. You will hear it being described as the opiate crisis. In the United States in 2020, there were 81,000 drug overdose deaths in the United States. Over 70% of these involved opiates. Unintentional fatal overdoses of narcotics now surpass car accidents as the leading cause of accidental death in this nation. There's about 1 million drug overdoses that are treated in our emergency rooms every year. Next slide, the patient is wondering, what on earth does this have to do with me? And it's a legitimate question, because you truly are caught in the middle. None of this is your fault, but you're affected by it. and so are we. It changes our relationship surrounding chronic pain in some very fundamental ways. Some of it's good because we've learned some things, and some of it's frustrating for both of us. For patients, sometimes they feel dirty, suspected of abusing drugs when they never have and never will. Physicians feel scrutinized and threatened by the Oregon Medical Board with loss of their license or their livelihood simply for providing compassionate care of patients. And so the next slide asks the question, what's lost sometimes in this argument, this righteousness that the establishment has found is, what do I do about my pain? Chronic pain has many causes, but it has this common destination. It is pain that extends beyond an expected period of healing. Now, depending on what process created that pain, it might be 3 months or 6 months. It's a very important diagnosis with a poor prognosis. And it quickly becomes complicated because the intensity of the suffering depends in part on the extent of the patient's fusion of his thoughts and of his emotions with the pain. And over time, that becomes very difficult to separate. So the next slide, a patient's thinking right now, so that's what you're offering me, nothing. It isn't. It isn't. At Evergreen, we don't agree that the best choice is to do nothing, but we do want to avoid harm. And so we've worked hard to develop an approach that we believe is safe and effective. What I'm doing right now is part of that. We're doing a lot of population and patient education. It's frankly a ton of commitment for the provider, but also the patient, but it's worth it if we can help patients get their life back. The next slide begins to speak about that. We start, and please read with me these assumptions. These are the assumptions that we base our treatment plan on. The first one is that chronic pain exists. And this pain creates a serious dysfunction of health and quality of life, not only for the patient, but for those around them. And it merits respect, it merits safe treatment. The second thing is that chronic pain is expensive. And I'm not thinking just of the treatment cost right now. I'm thinking of the loss of employment, the loss of social support, sometimes the cost to society and the abuse of prescribed drugs. It also includes the impact of street drugs or alcohol. And the third assumption, I'm talking about assumptions as we put together a treatment plan, is a mental health component. And I'm talking about emotional component and relationship component, either contributing to the expression of the chronic pain or resulting from the chronic pain, always exists. It's not whether or not it might be there, it always exists. Next slide. I'm going on with the assumption. And when I said it's kind of a downer to talk about this, hear me now, complete and sustained remission of most types of chronic pain is rare. It usually doesn't happen. So one of the really important things we talk about is setting expectations. A lot of people with chronic pain will benefit from opiate treatment, but others don't, and some are harmed by it. We believe, and again, an assumption that we make is every patient is entitled to a reasonable understanding of their pain process and what their treatment options are. And finally, we believe that the treatment plan and the conditions of the treatment should be clearly identified to patient. We want to be honest. We want to be open about the plan that we have. Go ahead to the next slide, Brian. And so we start with some principles that I started with assumption. These are now the principles that we base all of our narcotic use on. The first one is we're slow to prescribe narcotics beyond short term. And by short term, I mean maybe a week. We don't prescribe narcotics. I'm talking about at Evergreen. Now, we don't prescribe narcotics where there's not an objective diagnosis. That means something that we can some way be measure and be reasonably certain it exists without a diagnosis of a condition which would create the pain that's being described. We don't prescribe narcotics for conditions that narcotics have not been proven to help. Let me give an example of that. There's a diagnosis of fibromyalgia. It's real. It's absolutely real, but narcotics have clearly been shown not to help with that. Fibromyalgia is manifest by increased sensitivity to pain. Opiates further accentuate that hypersensitivity and really don't help in that management at all. There are other things that do, but opiates are not one of those. We use narcotics carefully, especially in certain conditions. An example would be untreated obstructive sleep apnea, untreated mental health disorders, a history of drug addiction or alcohol abuse. And we're very, very careful about combining narcotics with tranquilizers. At Evergreen, we don't prescribe narcotics to be used concurrently with marijuana. The legality of marijuana in this state complicates that, but we would make the same prohibition about combining narcotics with alcohol. It's just difficult to have control over potential adverse effect when there's that mixture ongoing. Next slide. Finally, with principles, we use the lowest effective doses and we don't exceed recommended standards of dosage limits. Usually this has to do with about 90 morphine equivalents, and you don't need to know what that is as a patient, just that there is a height beyond which further escalation of more narcotics haven't been shown to help and greatly increase the potential toxicity. The final thing, as far as our principles, we don't rely entirely on narcotics for pain management. We have an entire program. We use other medications which are synergistic, which augment the pain relief of narcotics. We also use a ton of other therapies. So I'm going to talk about those a little bit. Our next slide then acknowledges the hassle. And those of you that either are on a chronic pain contract or know folks that are understand what I'm talking about now. And we acknowledge that there's a hassle for patients. We do require that each of our patients who are on daily narcotics sign a contract. And this simply acknowledges what I'm presenting right now, that they're aware of the inherent risk and that they're agreeing to abide by our protocols. They also are agreeing to random urine drug test. They understand that we check with the Oregon Prescription Monitoring Program to make sure that patients are not receiving narcotics from other sources other than us. We do require provider visits every 3 months. We require an annual behavioral health evaluation, a mental health screen. And this will become more clear as I go forward why this is necessary. But if you'll recall, one of the assumptions I had was that mental health issues are always present, either contributing to or as a result of the chronic pain process. We don't adjust narcotic doses between visits, and we don't refill them early. The next slide. So, what can you offer? What all the hassle and all the preaching, what can you do for the chronic pain? You said you didn't do nothing, you had something to offer. What was it? The first thing that we should offer each one of our patients as they start down this road is an accurate diagnosis. For both of our sakes, we need to know, is there anything we can do beyond medication which could actually alleviate the pain? Is it a cancer? Is it some other issue that needs to be addressed in a different way? And so for both of our sake, this may take some time. It may take some diagnostic study and some consultation, but this is very, very crucial. We begin there. Secondly, it's the education component. It is what I'm doing right now. I'm going to speak later of a chronic pain support group that we have, and this meets every 2 months. We have a lot of options in terms of learning about the disease for our folks with chronic pain. But in this, one of the most important things we do is to try to set realistic expectations as to what we can accomplish. We do use medications beyond opiates. That medications may require antidepressant medications or medications like gabapentin or Lyrica, other things that augment how our other pain medicines use. Sometimes there's a medication called Suboxone, and because of the use of opiates, some patients develop an opiate use disorder where they become addicted to the medication. The Suboxone has proven extremely valuable for those patients where they don't have that same urge to escalate their dose. They have adequate control of their pain, and also addresses any withdrawal or cravings. And so we're very active in this as well. And then the behavioral health support has to do with recognizing the emotional aspect of it. Evergreen's behavioral health interventions are based on an approach called ACT, acceptance and commitment therapy. And the power of ACT is how it connects changes to our values. What I'm going to say now is going to be hard for folks to understand, and I may speak a little bit more about that in the questions if there are that. But while pain hurts, it's not the struggle with pain that causes the suffering. And I'm speaking not of physical pain, but while the pain itself hurts, it's actually the struggle with pain that causes the suffering. Now, ACT utilizes mindfulness so that we establish a sense of self that's greater than just our thoughts and emotions. You preserve and you separate that self from the painful experience. What I'm trying to say is you don't lose yourself to the pain. You maintain your identity, and you can observe your pain without becoming your pain. You separate the feeling from your pain. I'm talking about a behavioral health approach, because regardless of how strong they are, your feelings will change. Each of us have had strong feelings about someone or some issues in the past that you hardly feel anything about today. Feelings are in constant motion. And so you notice who is noticing the feelings and understand it's you that give the feelings power. We require folks and work with them to identify their personal values that direct their life compass. When we connect with their values, we set a foundation where we want our life to be. And then we now never allow other people or other events to chart that course. So we don't deny the suffering. I want to acknowledge that, but we spend so much time asking where the suffering comes from that it leaves a little time to ask where it leads. And with ACT, we're looking forward. Next slide. So as far as other things beyond the things we spoke of, what we offer at Evergreen Family Medicine, we're very engaged with AIM and the director of AIM in regards to physical therapy. There's a difference between passive therapy and active therapy. I think of passive therapy as maybe in massage. It's where the patient lies there and says, do it to me. And putting hot packs and massage and so forth is helpful in that degree. Active therapy is what you do for yourself. It's swimming or aquatic therapy. It's walking. It's other working out. And I will tell you that the gain from active therapy is much more and lasts longer than that of passive therapy. There's a lot of other alternative treatments that we encourage, from massage, chiropractic, acupuncture, injections, sometimes exercise. The chronic pain support group is a huge resource to our people in this area. It's an area where, as people who are sharing not necessarily the same pain experience, but a lot of the same challenge, we support one another. There's a lot of education in there, as well as a planned agenda. The next slide there. And so I will tell you that if you know somebody with chronic pain or just want to learn more about how you can support somebody with that, we meet every other month. It's scheduled in the afternoon. It lasts an hour. The structure is that we have about a 30-minute presentation on something like I just did. Then we have a time of group therapy and where we talk as a group, and we also meet individually with people there to do a behavioral health screen. Next slide. These would be an example of some of the presentations that we do coming up on the 22nd. Dr. Moffat is going to talk about the physiology and pharmacology of pain. In the next one, Dr. Myers is going to talk about alternative treatments. You can see Brian Saline, who's a doctor of physical therapy, is going to be talking about that role and some things that he found to help with chronic pain. Dr. Bonds is going to be talking about how we measure success, and he's going to bring patients in to really talk about some obstacles and the way they were able to overcome. And so there's a number of presentations, and those will change time to time. And you know what, Brian, I think that might be our last slide there. So I think I'll stop jabbing and be ready to answer some questions.
Great. Yeah, you're hitting home, I think, for a lot of people. I think of people that I know in my family, especially with fibromyalgia, and you talk about the connection to behavioral health, and you talk about just the knowledge that it exists is something that they struggle with, trying to convince people that this is real. And wow, it gets very personal and very important to people, like, very quickly. And sometimes it's hard to know exactly what to say or do. So
the impact on people's lives, Brian, is so profound, and the impact on their self-image, their confidence, and their relationship. It's just a critical. Some folks like to avoid, in terms of providers, the treatment of chronic pain. You better avoid primary care then, because it's part and parcel of what we do, and it's just part of the human struggle.
Mm-hmm. Well, we have some questions here. Plus, of course, if anybody out there on Facebook or YouTube wants to ask some questions, now's the time to pop those into the chat. And we do have some questions that are queued up. So the first one's fairly simple, Dr. Powell. What causes chronic pain?
Yeah, that's a great question, Brian, and it's not at all simple. Patients and people, I should say people, experience acute pain differently. And most of us are aware of that. You can have the same event, same seemingly stimulus. Maybe somebody broke a wrist, or they're going through labor. They have headaches. A young kiddo falls on the playground and scrapes themselves all up. But it induces very different responses in people. And a lot of that reflects how individuals respond differently to the pain. And that's based on past experiences, on the level of fear involved, how safe one feels, the level of support. If you have a labor patient who has a husband there, they've gone through the prenatal classes, they kind of know what to expect, they feel a little bit in control. That's very different from perhaps a young individual who lacks all of those things. There's learned expectations of how we respond to pain. And then, of course, there's different personality types. They all play a role. Now, in chronic pain, there's always an initial basis, always why it started. And that source is legitimate. We never question that. But the question is, why does one individual recover and move on, even if the pain does not fully resolve, where one with chronic pain continues to experience an element of disability and active suffering months and years later? And so the initial provoking thing may be previous trauma, back pain, headaches, arthritis, diabetic neuropathy, all of which people really do have, and all of which other people have. But in chronic pain patients, this process becomes a central focus, and it becomes a limitation in their lives. Now, I want to go on to say these patients are not making it up. Please don't hear me that way. The pain is real, but it's also critical to understand what gives the pain experience its powers. And frankly, that's what makes us human.
Another question that we have is, what medications other than narcotics will help with pain?
I'm glad somebody asked this because let me repeat. On the 28th, July 28th, 3:00 p.m., we're going to have our next chronic pain support group, and the entire hour is going to be purely on this. Dr. Natalie Moffat is going to be talking about the physiology and pharmacology of chronic pain, and it's very, very interesting how our body interacts with the pharmacology that we feed it to the response. Anybody can join us by going to our Evergreen Family Medicine website. You go to resources and you look under that, you'll see the chronic pain support group, and join us. And I hope they do.
All right. Next up, how can I help as a spouse of a chronic pain patient? You might also put a son, daughter, grandchild of a chronic pain patient on that too.
You sure can. And you can put any family member, you can put a friend. And I will tell you, this can be a tough walk. You want to support, you want to encourage without enabling dependent behavior, without nourishing the focus on pain and disability. Let me say first, it's important that you're not consumed in the process. There can exist a vortex of negativity in this individual that can draw in bystanders, and it can deplete the most generous individual store of goodwill. It's important to understand your role. You don't try to be their therapist. You aren't their caregiver. You're a listener to a problem that it's not your responsibility to solve. I encourage those supporters to keep the focus on function, not the pain level. To encourage the individual that's afflicted to get out with friends and for social events like ball games or concerts, movies, shopping, church, to distract and to diminish the isolation they seem to crave. You can be empathetic without pity. You can acknowledge the pain and the frustration without living there. And that can help the patient move to acceptance. It may seem cold when I say acceptance of that, but our ACT, acceptance and commitment therapy, begins with an approach of saying, in essence, I'm sorry, it looks like your chronic pain is not going away, and then moving on. And I will tell you that approach can be healthy.
Very good. Someone wrote, you said something I don't understand. You said, while pain hurts, it is the struggle with pain that causes suffering. Can you explain that more?
Yeah, I knew that was going to be confusing when it came out of my mouth. While pain hurts, it's a struggle with pain that causes a suffering. I used the term acceptance a moment ago, and I'm referring to accepting the presence of a distressing, unwanted experience. Now, accepting it doesn't mean you have to like it, but it does mean it doesn't define you. Some people lose themselves in the problem. They no longer have a sense of self. They've lost their identity to an experience. It may be rape, it may be a childhood sexual abuse or other abuse. It may be chronic pain. This acceptance helps place this event external to you. And this is a hard thing, but let me have you envision something. Envision a person watching a computer screen. And so you watch it, maybe as you're watching me right now, what you see is real. And your experiences, you see your experiences on there. Sometimes I say, it's like watching out the window at the cars going by. The cars are real, they're going by, it happened. But you see a thought or experience and you notice it, but you don't invite it in. You can observe your pain without becoming your pain. Now, as you think about that a little bit, you might say, so who is you? Who's doing the watching? And I will tell you, this is the person who's always been there. From the first time you can remember any thought about yourself, is that person is the one who showed up for kindergarten on the first day. That's the person you want to place in a safe place and separate from all the crap that has happened to you. You're going to either be carried by your history or you will carry your history. Now, there's some things we talk about in our counselors as we deal with people with these unpleasant experiences. And let me define two things. Fusion is when your chronic pain or the abuse, the failures, the disappointments, the losses, when all that becomes a part of you, and it increases horribly the power and the complexity. Diffusion is when you separate those painful experiences from the person. You separate it, and this lessens, hopefully takes away the power, but it certainly does that. And it is why I say that pain is inevitable, but suffering is optional.
Well, it sounds like the kind of thing that you probably talk about in the counseling. So it's perfect to have this one come up next. Can you talk a little more about ACT, the type of counseling model you use?
Yeah, I'd like to. ACT is basically a format for our primary care intervention that we use in all manner of counseling. And it starts here. All change is tied to values. Change is always tied to values, not goals. A value is a principle for living, where a goal is an achievement. So we change a goal into a value. A person says, my goal is to graduate from college. We turn that into a value. My value is education, continuing education, because values allow more durable behavior. They allow more durable behavior changes than goals, and they also offer a higher probability of success. You're still following your values, even if you don't necessarily meet all of your goals. And so when a patient mentions some achievement that they consider critical, as you get in with the patient to understand, where are we going? Where do we want? What is the life path that we want to achieve? We ask always, when they mention some achievement, we will always ask to understand, in service of what value. And the reason you want to have the patient personalize change to values is you can't argue with yourself. These are your values. And so you create an image of the life, not that the patient has, but the image the patient wants based on their values in reality. And then you ask the question, what would it take to get there? Sometimes I've done this in an exam room. I've just set two chairs apart, 6 feet apart, but facing one another. And I'll have the patient look at the first chair, and I'll say, this is your life now. I just look at it. That's your life. This is where you are. And the other chair, that one's behind you, is where you want your life to be. What would it take to move in that direction? And what it takes is, first of all, to remove the focus on the first chair, on their pain and disability, and begin to turn just a little bit in order to see a different possibility. Because as long as their focus is on that first chair, they can't even see where they want to end up.
Well, get ready for a little bit of a challenge to some of what you just said. So much of counseling is about feelings and fluff. It seems like a waste of time. Can you give an example where that ACT model actually helped solve problems?
Well, that's kind of where the rubber hits the road, isn't it, Brian? People sometimes undergo endless therapy, and that's rarely useful. Honestly, it'd be like endless physical therapy. You're there to reach a place and to learn to help yourself. So our model is very pragmatic, and it is actually patient driven, because we try to work with the patient to see how much flexibility they have. Some patients are very rigid, and also how motivated they are, because sometimes patients are happy with the disability. They don't really want to move on, and you might as well acknowledge that. But a lot of times there is ways that we can help them move in the direction of what they want by understanding, really connecting with their values. I'm wandering here a bit, but let me say this. There's an adage in psychotherapy, an old adage, and it says this: the problem is not the problem. The solution is the problem. Now, that's true in chronic pain, because a lot of times their solution has not helped them. But let me illustrate it in a different way. And here are two actual cases that we have dealt with. So the young man, he was in his early 30s, and he came to see his primary care doctor, and his problem was he couldn't sleep, and he wanted medications to help. So that was his problem. He couldn't sleep, and he had a solution. He wanted medication to help him sleep. So we took a history. This young man had been involved in a motor vehicle accident about 6 months earlier, and his brother, also in the vehicle, had been killed. He and his brother were very close. They had been in business school together, and their intention was to practice together as accountants. And with that motor vehicle accident, along with his brother, a dream died. Now, the patient found it really hard to care about anything. He was drinking more than he should. He had a lot of tension with his girlfriend. He wasn't functioning well at work. He had become withdrawn socially. So that was the problem. As understood by the patient, he couldn't sleep, and understood by the provider, he was depressed. Now, I will tell you, most providers, a standard response in that situation would be to empathize. It's hard not to prescribe an antidepressant, instruct the patient to drink less alcohol, suggest a bereavement group to which he would never go, and see him back in a month. But I want you to remember my quote: the problem isn't the problem, the solution is the problem. And I want to know if you can see that here, because not sleeping really wasn't the problem. It was the way that he was dealing with his grief over his brother's death. It was the alcohol. It was the isolation of people. That was his solution. But when we connected with him, his solutions didn't reflect his values. It didn't reflect his brother's values. And so by redefining the problem, not as not sleeping, but as how to best honor his brother's memory, his brother's life, it became clear what he needed to do. He understood he needed to pursue his career with the passion and the excellent, befitting a shared dream with his brother. And we were able to turn this into much more positive energy and a better way to honor his brother's memory without medications. A second example would be this, and both of these involve this ACT model, but the power is in the patient. Let me say that the power is with the patient connecting to their values, but willing to work with is in that. So a young mother struggled with bulimia, and despite her best effort, she found herself late in the day. She would always induce emesis, and then she would feel just disgusted with herself and feel like a failure. She'd fight the urge all day, but then late in the afternoon, it seemed like she would give in. She came to the doctor because her problem was a constricting feeling in her throat that was very uncomfortable. So her problem was that throat feeling, but she also wanted to make herself stop this purging activity. So our therapist got involved. And the first thing he did is he said, I want you to back up, and I want you to walk me through your day. What do you do first thing in the morning? And of course, she took a shower like most of us first thing in the morning. And then he asked her, what do you do when you get out? Well, of course, she looked into a mirror and she was very unhappy with what she saw. The therapist asked, is there a memory that's coming along for the ride? She remembered being a child and being by far the biggest girl in her class and being teased for being so big. The therapist had her get in touch with those emotions. And I'm talking now kind of getting to that acceptance thing that I spoke to. And she acknowledged feeling really embarrassment and shame with that feeling. And so he put a label on that. Sometimes it's good to put a label on that and put it outside the person. So he called it that self-hating feeling. And then he asked her if she had any physical sensations at that time. She touched her throat and she talked about the tightness and that foul bile feeling. And then he continued to walk her through the day until the point where she was inducing emesis. The therapist then asked her to go back and ask her if she could separate her emotions and her memories from who she was. He changed that self-hate label to flawsome. And he asked her if she could choose to say, I deserve to treat myself with kindness, even when I look at my imperfections. And then he told her this, I'm not very interested in what you've described as the problem. And so he held his hand out like this. And he says, I'm much more interested in what happens at the front of the day when you're having these self-hate feelings. And I wonder, are you able to just look at yourself and not evaluate you? And every time through the day, when these feelings come, you look at them, but you just notice them. They don't control you. They're not you. You are flawsome. Because otherwise what happens is this thing just builds up steam and momentum all day long. And by the time it gets to the point where you're throwing up, that's the wrong time to stop a train. And so in each case, what I'm trying to point out is the problem was not the problem. It was the chosen solution that was the problem. And by redefining the problem, connecting with values, the patient was able to come to their own conclusion on how to address those.
Okay, Dr. Powell. Well, that pretty much brings us to the end of the presentation and of the questions. And we just want to remind folks that we're here on the second Thursday of every month at 4:00 for Evergreen Talks, the monthly Facebook Live event where physicians and providers and specialists at Evergreen present topics that matter to you. Also, we want to make sure that people know they can go to evergreenfamilymedicine.com for more information. And as you may see and hear occasionally on YouTube or in the lobby televisions. And you can follow Evergreen on YouTube, Twitter, Instagram, and Facebook. Dr. Powell, any closing thoughts to today's presentation?
Only this. I really do encourage either people that struggle with chronic pain or supporters or somehow related to them to consider joining our group in the chronic pain process, and encourage those people. There's a lot of folks that are resistant to behavioral health or mental health component with that, but I will tell you that until we've been able to accept this and work with it, it's very difficult to really reach the quality of life, which is what we care about most. We accept what we can't change, but we don't accept that what can't change has to impact or restrict that quality of life. And so we work on that portion.
Great. All right. Well, thanks again for your time. Thank you for everybody who's watching on Facebook and on YouTube. And we'll be back again in a month on the second Thursday of the month for the next Evergreen Talks. Dr. Powell, I hope you have a great day. Enjoy the sunshine, and we'll see you again soon.
Thanks, Brian.